Good morning and welcome to you all on this final day of what has been a great Value in Health week. In this session, the panel today will be describing to you the progress to date and future actions of a value-based healthcare approach to improving diabetes prevention and care in Wales. My name is Claire Green and I am Deputy Director for the Finance Delivery Unit. And I'm very pleased to open this session this morning with a great multidisciplinary panel who are all working to support improvement in prevention and care for people in Wales and people living with diabetes. Joining us for the session this morning, we have, as I say, myself, and I'm going to talk to you a little bit about a recap and approach today. Dr. Julia Platts, who's going to be talking to you about the current position of diabetes in Wales. We have Dr. Amrita Jesaraza, a consultant in public health and the All Wales Diabetes Prevention Programme lead. We have Dr. Sarah Davis, a GP partner from Cardiff and the All Wales Primary Care lead for diabetes. And in the beauty of live technology, we should have Scott Corley, MBE, our National Diabetic Foot Coordinator for Wales, who is currently transitioning between locations in the hope that he will join us for this session today. So we do hope Scott can get here. Between us, we're going to talk you through a recap of the origins of this programme of work and the progress and developments to date. We will reflect on the current position in Wales concerning diabetes prevalence and the multi-layers of prevention and intervention under review to support an improvement in the adverse outcomes reported for people living with diabetes in Wales. Next slide, please. I'm aware that some of our audience today may have joined us for this session at Value in Health Week last year when we were at the inception of this project, but some of you may be new to this particular programme of work. So as a brief recap, this is a national project and a proof of concept approach progressed in diabetes, thanks to Julia, who responded to a request to national clinical leads to take a new approach to connecting and reviewing data and resource utilisation for a specific condition. The aim is to unlock and enact improvements for people living with diabetes. And to achieve this, we are viewing diabetes through a value-based healthcare lens, working in partnership as clinical and financial leads with strong analytical support. We have sought to maximise the integration of data across the system to analyse outcomes, pathways, interventions and socio-economic factors to identify variation and potential drivers of variation in outcomes for patients living with diabetes. The ultimate aim is to identify where and how we may need to shift resources upstream in the patient pathway to prevent some of the adverse outcomes being experienced by patients. Due to the multiple health complications which people living with diabetes may experience, the project is initially focusing on 3 subspecialty pathways: foot disease and amputation, eye disease and diabetic retinopathy, and diabetes and pregnancy. And although the range of data already is available, it does expand to the wider diabetes population. Perhaps unusually and with intention, we are using reported adverse outcomes in each of these key areas as the start point and mapping backwards from the adverse outcome to gain insights to key high-value interventions and services experienced by patients alongside socio-economic and population health data in an attempt to understand where and how service models may be improved. Through the panel today, you will hear how this work has developed and with the initial subspecialty pathway of foot disease and amputation. Next slide, please. So what has been our approach since we were talking with you last year? So during this year, we released version 1 of the Diabetes Insights and Variation Atlas, which can be accessed by anyone within NHS Wales. The initial data included in the atlas was focused on 2018-19 as the baseline year, which on reflection is a helpful start point as we build in 1920 and future years, as we'll have an understanding of trends prior to the pandemic. The atlas currently provides users with a system view of amputation activity and information across Wales of people living with diabetes, which is drillable from system level down to health board and down to a GP practice. The activity is identified by full ICD-10 classification of diseases, and for this pathway review limited to amputation pathway by OPCS codes. The atlas visualises prevalence data, amputation activity, hospital spells, length of spells, average cost, which is all based on an All Wales patient level costing data. We've got patient case mix and crude mortality alongside the Welsh Index of Multiple Deprivation. There is also data within the atlas which supports an assessment of interventions and management of diabetes, such as blood glucose, HbA1c testing and primary care prescribing. We are weeks away from launching version 2 of the atlas, which will present 1920 fully costed activity for this pathway and already includes 2021 activity, which will be fully costed by the new year. The atlas has been extended to include not only Welsh provided activity, but English provided activity for Welsh patients. We have extended the primary care prescribing data to include insulins, a multi-year data drillable to a GP practice level, and multi-year HbA1c data that's visualised for the whole tested population with a detailed trend assessment across 5 years for those patients with diabetes who have had an amputation. If you were able to join the keynote session this week, you may have heard Helen Thomas at DHCW describe that we have lots of data in Wales, but we are limited in information. And this atlas has turned vast amounts of data into helpful information and insights for the system. It is constructed with visual ease for all users to identify both the variation and opportunity to improve outcomes for the people of Wales, and by providing data and evidence to inform future decisions that support both the treatment of patients and to inform future approaches to improving population health. We've established a clinical reference group, a number of whom are part of the panel today and who are supporting both the validation and iterative development of the atlas to provide information analysis that is most helpful to the system. We have supported a very energetic and ongoing process of engagement across the health service in Wales of both the availability of the atlas and the analysis available and the conversation developing of the so what. We have engaged with the lead of the National Clinical Framework, Adam Wardle, who you may have heard talking earlier this week, creating alignment to the clinical plan and approach in Wales and ensuring we turn data into knowledge and knowledge into practice. We have met with executives in Welsh Government, directors of finance across Wales and clinical and operational leads across health boards. We very quickly became aware of all interventions across the pathway and the importance of each component. We have to focus energy on preventing the growth in type 2 diabetes, but we must also ensure that high value interventions are in a place for those who do have diabetes at all points in the pathway. The research available in the power of prevention is undeniable, and we have a role to play in all tiers of prevention, primary through to tertiary. The last area I would summarise in our current approach is partnership, and pinch with pride or even steal with no shame are both statements that I fully support in the case of health evidence, and you may have heard Howell Jones describe this yesterday. We do not need to reinvent the wheel when locally, nationally and internationally evidence is available on how to optimise prevention and care for patients whilst optimising the utilisation of resources to gain the best outcomes that matter to patients. The National Diabetes Audit undertaken annually is an incredibly rich data resource for use within Wales and across the UK. And we also in Wales have the honour of being part of the World Economic Forum Global Coalition for Value, which provides us with peer-to-peer access to both Diabeta and Steno. We have recently made contact with Steno, who report an 80% reduction in the amputation rate of people living with diabetes. So we will be exploring these partnerships and learning further in the coming months. Next slide, please. So finally, before I hand you over to clinical colleagues, some reflections from me of the project to date. Just a few things really. Data, sometimes there's more data in the system than you realise, and we seem to have surprised and encouraged people with the data we've been able to bring into the atlas, and aligning just a couple of data sources can be incredibly insightful. Connecting data is brilliant, but it does not need to be fully matched, perfect and connected to give you valuable insights to variation in outcomes. Information governance has certainly been a learning curve, and it is a challenge, but it is also a very clear process and a methodical approach, and therefore is definitely not a barrier to progress. Partnerships, as I noted, of clinical and financial teams and the extension of this to operational teams are fundamental. A key partner is also planners, who are integral to the implementation of the long-term changes we are trying to achieve. Informatics and analytical experts are also key, and the work of the Finance Delivery Unit Information Analytical Team has been exceptional, and they are the architects of this insightful atlas. Communication engagement, as I've described, is also pivotal to progress. You may be wondering about the so what, and I'm very happy to share this programme of work has led to diabetes being on the radar in many arenas. The Health Minister has noted the work and intended focus on diabetes in recent talks, Diabetes is a focus area of population health and outcome improvement for a number of health boards now in Wales, and you'll hear shortly how this programme of work is developing a data-driven system and is gaining great pace. As you may have heard this week, the Value in Health strategy is due to be released today, and the strategy acknowledges that a value-based healthcare approach requires consideration of the whole pathway of care so that we make informed decisions regarding optimal utilisation of resources to achieve the best outcomes. It also highlights that we achieve value for our population through the sum of all interventions across the pathway, and hopefully you will get a sense of the work progressing across the whole pathway in diabetes in Wales to truly deliver on this approach. And one very quick last point from me to share, this is a personal reflection as well as a final one, that this is a marathon and not a sprint. At the keynote session at the start of the week and at the Value-Based Healthcare Around the World session yesterday, you may have heard reference to the need to create a cultural shift, and that sometimes things feel really hard to do and that continuous adaptation is required to transition to a value-based healthcare approach. And this is all true. However, training for a marathon is simply a multiple of sprints, and by working together and with patients at the centre of healthcare delivery, we can achieve the delivery of a data-driven, sustainable health service that optimises the utilisation of resources to deliver outcomes that matter to patients. So I will now hand you over to Julia to talk to you about the current status in Wales.
Thank you very much, Claire. I'm Julia Platts, National Clinical Lead for Diabetes in Wales. And can I just say at the start, what a pleasure it's been to work with Claire and Kim in the Finance Delivery Unit. We're all aware of the burden that is diabetes in Wales. We know about the personal burden, we know about the healthcare system burden. We've got over 200,000 people living with diabetes in Wales. The vast majority is type 2 diabetes. That's 7.6% of the population over the age of 17. We know that there's a large amount of people with undiagnosed diabetes. We don't know exactly how many, because the pandemic is likely to have had a significant impact with people putting on weight, having a less sedentary or more sedentary lifestyle, and the reduced testing, the blood bottle crisis. So we've probably got a tsunami of type 2 diabetes waiting in the wings. We've also got around a sixth of our population at high risk for diabetes in Wales. Next slide, please. This slide just demonstrates that increase in diabetic prevalence over the years, with the dark blue being type 2 diabetes, the light blue type 1 diabetes. And we can see the different prevalence across the health boards, with diabetes being most prevalent in Betsy Cadwallader at 8.2%, least prevalent in Aneurin and Bevan at 7.1%. Next slide, please. Diabetes also has a significant financial burden as well as the personal burden. We hear over and over again that it consumes 10% of the health budget. And what we know that the vast majority of this 10% of the health budget is spent on managing complications such as amputation. And what we do know is that effective care will reduce and possibly prevent complications. And what is important is that this effective care is early on in diabetes rather than later on in diabetes. Next slide, please. So these are some of the complications of diabetes, which I'm sure everyone's well versed in: the cardiovascular effects, strokes and heart failure, the fact that a fifth of our inpatients in hospitals across Wales will have diabetes. Blindness is the most feared complication by people living with diabetes, end-stage kidney disease, amputation, ulceration, disability, which is what we're focusing on today, and then all those increased pregnancy adverse effects. Next slide, please. So next slide, thank you. Why does diabetes cause foot problems? Well, we know that diabetes affects the small vessels, which are the small vessels to the nerves. This causes nerve damage so that people lose sensation in their feet, and therefore it's fairly easy to get a rub to the foot or a burn to the foot, or even step on something without noticing, which causes trauma. And in the worst cases, people can even fracture bones in their feet and not know about it. We also know that this nerve damage will alter the shape of the foot, and as a result, there'll be abnormal pressure points in the foot, and this is what tends to ulcerate. We know that the autonomic nerves are affected as well, and that will lead to the skin being dry and cracked, which allows infection. We know a really major factor is the reduced blood supply. Diabetes affects the large vessels as well, and that causes reduced blood supply. And this is a major factor leading to amputation. We know that if you've got diabetes and high blood sugars, you're predisposed to infection. And there's also a situation where you get Charcot feet, where the foot anatomy becomes very disordered. Next slide, please. So we know that diabetic foot disease is very, very costly. For example, in 14 to 15, diabetic foot disease cost the NHS 1 billion, which is around 1% of the total NHS budget. And that's not even taking account the effects of disability, loss of work days. At any one time, we think 64,000 people have foot ulcers in England and Wales. And we know that there are around 7,000 minor and major foot amputations in England every year. Next slide, please. So there are opportunities to prevent amputation, which we need to think about, and then we need to think, are we taking these opportunities? The first one is obviously preventing diabetes if we can. We know there's an opportunity to prevent type 2 diabetes. Secondly, good glucose control from diagnosis. We know that this will reduce the risk of damage. Thirdly, in those people with diabetes, are we screening for nerve damage and therefore protecting the foot, changing our footwear, changing our foot care? And are we finding reduced blood flow, which is often something can be done about it? There can be vascular intervention. So then if damage does happen, if people do develop a foot ulcer or problem, how quickly can they get to the experts, the MDT? Then what can the MDT do to heal this ulcer? And then when people end up in hospital with acute complications, such as infections and gangrene, what can we do to help them? So let's see how we do in Wales with some of these opportunities. Next slide, please. Firstly, good glucose control. How do we do? Well, I've chosen a target that's not particularly tight control. It's sort of realistic, of an HbA1c of less than 58 millimoles per mole or less than 7.5%. If we look at the 1920 audit data, for people with type 1 diabetes, we achieved this in 27.5%. For people with type 2 diabetes, 61%. So I think we can see there's a lot of room for improving there. Next slide, please. How do we do on screening people for that loss of sensation, the loss of blood flow? Is this another missed opportunity in Wales? Next slide, please. Sorry, this slide is rather busy, but what we're looking at here are the 8 care processes that people with diabetes are supposed to have annually. This slide is just for type 1 diabetes. The top table is England, the bottom table is Wales, and going across, it's the last 5 years. And if we look at foot screening in England, it's stable at about 75%. If we look at foot screening in Wales, it's fallen from 5 years ago, 62.3, to pre-pandemic, 47.7. So why is this being maintained in England and why is it falling so drastically in Wales? Next slide, please. This slide just shows the same for people with type 2 diabetes. You can see foot screening is maintained at around 85% in England, and in Wales it's fallen from 81% to 68.6%. So again, a similar drop-off. Next slide, please. Do we heal the ulcers? This is another opportunity to prevent amputation. We find that less than half of all ulcers are healed at 12 weeks. And if they're a severe ulcer, only a third of them get healed at 12 weeks. So this is another opportunity to do something to prevent an amputation. Next slide, please. What we do know is the time from the development of the ulcer to seeing the specialist team really matters. So this slide shows people who are alive and no longer have an ulcer at 12 weeks. And we find that if they're able to refer themselves in, 54.5% will be alive with healed ulcers. However, if it takes them over 2 months to get to see the specialist team, at 12 weeks only 35% will be alive with a healed ulcer. And there seems to be a tipping point at 14 days, that if it takes longer than 14 days for somebody to be able to get through the health system to the expert team, there are worse outcomes. Next slide, please. What happens in hospital? The National Diabetes Foot Audit collects data on foot problems, and the data shows over 90,000 hospital bed days related to foot disease within 6 months. And this is significant because we think that the National Diabetes Foot Audit only actually gets about 10 to 20% of the cases. So what that means is that the bed days could be 5 to 10 times worse than we've got displayed on this slide. Next slide, please. So what are the next steps? We have taken our practice and we've put it into data so that we are able to examine it. Our next steps are extracting the knowledge from this data, and then the knowledge that we've extracted from this data we need to put into practice. And what we want this practice to be is innovative practice focused on getting to the heart of the problem. What we don't want to do is to continue to do the same thing and expect to get a different result. Next slide, please. I'm now going to hand over to Amrita, who's going to talk about prevention of diabetes. Amrita.
Thanks, Julia. So my name's Amrita Jessarel, so I'm a consultant in public health in the primary care division of Public Health Wales, and as Claire mentioned, the programme lead for the All Wales Diabetes Prevention Programme. Firstly, just wanted to say many thanks to Claire, Julia and Sarah for the opportunity to present today, and that we've also been working together on this programme, so it's really great to be able to present the full pathway with you. So firstly, about the All Wales Diabetes Prevention Programme. This builds on pilot approaches that have been undertaken in Afan Valley and North Ceredigion, where a specific brief intervention was offered to a targeted population. The programme is Welsh Government funded and led by Public Health Wales, with the intention to establish a phased rollout of this intervention with inbuilt robust evaluation delivered through primary care clusters across Wales. Welsh Government have made a funding commitment of £1 million per year for a 3-year period from this year up to 2024. And our intention is to work with all clusters to share the learning from and support the alignment to the All Wales Diabetes Prevention Programme. The fund is for a phased rollout with evaluation, so there'll be a limited number of clusters initially, with at least 2 clusters per health board in the first wave of implementation. The other thing to mention is that this is very much aligned to the Healthy Weight, Healthy Wales strategy, and in particular the All Wales Weight Management Pathway, which was published earlier this year. We recognise that there are an awful lot of developments happening with regard to weight management, and that our approach with the Diabetes Prevention Programme is therefore a value-based one, where we're recognising these very related and parallel developments and trying to adopt an integrated approach. Next slide, please. So there are a number of questions at the start of this programme to explore in terms of the who, what, where, when and why of the programme. And so I'll take you through these now. Next slide, please. So firstly, why? Julia's already highlighted that there's a number of people who are potentially at risk of diabetes, potentially a tsunami as she described, with the pandemic and the increase in sedentary lifestyles potentially increasing this risk, even though the risk was already high. So prevention is a really key aspect to consider, and given the potentially severe and catastrophic consequences of diabetes, we know that prevention is better than cure and that the value of prevention is clear. Whilst the Afan and Ceredigion approaches have definitely demonstrated their promise in terms of effectiveness and reducing the risk and delaying the onset of diabetes, the need for considering the evaluation of this programme as it stretches out to all clusters in Wales is clear. We know often that something which works in one small area has challenges as it's rolled out further, and so that's why we're taking the approach for this phased rollout with embedded evaluation. Next slide, please. So firstly, we needed to establish the programme. So we have a steering group, which Julia is a member of, and Sarah's involved in a number of the work streams which sit under this programme. We have a work stream that's been looking at the design of the intervention, taking the work that's done in the original pilot, looking at the NICE guidance and the evidence base, and then creating the design for the All Wales Diabetes Prevention Programme, very much aligned to these initial pilots. We've been looking at the delivery and the distribution of funding, and at the detailed evaluation, which takes both process, outcome and value-based evaluation into consideration. And really key to all of this is engagement with stakeholders and communication of how we're trying to deliver the programme, so that this is a key area of work as well. We report upwards to the Healthy Weight, Healthy Wales National Implementation Board, and we're very much working in partnership with the Strategic Programme for Primary Care and the Building a Healthy Wales Coordinating Group. Next slide, please. So with regard to the intervention itself, what is the intervention? What are the core elements? The first thing to consider is the patient identification. Would we consider case finding, and what are the eligibility criteria? Who would definitely be included and who would either be excluded, or would we need to consider whether the intervention was appropriate and that an alternative may be better? Within the intervention itself, which is a brief intervention with a healthcare support worker having a structured conversation with the patients, and that's supervised by our dietetic colleagues, the content, purpose and structure of that intervention all needs to be considered. There'll then be onward referral and signposting to support services, and this will in particular be in line with the All Wales Weight Management Pathway. And then the key bit is the follow-up after a year to remeasure the HbA1c and to see whether there's been a reduction and whether prevention has been successful. Next slide, please. I've mentioned already that healthcare support workers and dietitians will be key key professionals involved in the delivery of the intervention. There may well be others who need to be involved, and that's something that we have to consider in the delivery model. We also need to think about where will the intervention be delivered. The pandemic's obviously posed lots of challenges, so whether we need to consider continuing with an element of virtual consultations or face-to-face, what are the key setting or settings, and we're very conscious of the challenges around accommodation for new initiatives in particular. We also need to consider a number of other issues, such as how we invite patients to the intervention, data collection, phlebotomy, processing of results and the evaluation methodology. Next slide, please. So, just for clarity, the stages that we're in at the moment is the design stage, where we've been looking at the intervention design, the delivery model and the evaluation approach. We aim for implementation of the programme to begin in March 22, and this is what we would hope would be the first wave of implementation of the programme. The hope is very much for subsequent waves, but that's obviously pending further funding, and that would need to be increased funding and sustainable funding to be able to deliver in all clusters. But we anticipate that by going live with delivery and feeding through the evaluation results, that this will build a case for that sustained delivery in all clusters. Next slide, please. So to conclude, the key milestones for the programme, which we've covered mainly already, are the establishment of the programme. I'll come back to evaluation in a moment, but agreeing the intervention design and delivery model, identifying those initial clusters that will be involved in the first wave of delivery, completing the recruitment of the key health board staff to support the delivery of the programme, and then commencing delivery in March. With respect to evaluation, the evaluability assessment happened earlier this year, and as well as the commencement of the academic tender process. And as I described in the elements of the programme, there were those three different elements: outcome, process and value-based assessment. And again, this is where the diabetes data and information that Julia and Claire referenced earlier is really key, because that's what enables us to track the prevalence of diabetes in Wales and to have an understanding at a population level of whether the programme is making a difference. Thank you so much. I think that's my last slide. The final thing that I wanted to mention is that we have a stakeholder event where we go into some more detail on the answers to those questions. I'm conscious that I've mainly presented the questions and the work that we've done, but we do have many of the answers coming to those questions, and so please do get in touch with us if you'd be interested in joining. Thank you very much.
Thanks, Amrita. I think it's over to me now. Lovely, thanks everyone, that's great. My name's Sarah Davis. If you missed the initial introductions, I'm a GP first and foremost at Woodlands Medical Centre in Ely in Cardiff, and I am the National GP Lead for Diabetes. And we've been hearing some fantastic, exciting stuff, haven't we? Finally, brilliant, a rollout of a national type 2 diabetes prevention programme in Wales. Hooray! That's superb news. And I'm sure we're all really excited, and I'm really enjoying being involved in the rollout of that. And indeed, the data that Julia was showing us from DIVA, from the Diabetes Variation Atlas, is absolutely brilliant for us to have access to. What I want to talk about for the next 15 minutes is very much the primary care role in foot care in diabetes. It comes back again to prevention, indeed to screening, and indeed to multidisciplinary working. And I want to talk a little bit about accessing our data in primary care in a really easy access way that's going to help us to improve our care. Thank you. If we can just click through the slide, that's brilliant. So Julia's already talked to us in the introduction about the role of neuropathy in foot issues in diabetes. And we know that peripheral neuropathy is extremely common in people living with diabetes, both type 1 and type 2 diabetes. In fact, it is the commonest complication of diabetes. We probably think about kidney disease, retinopathy, but actually neuropathy is the most common, with peripheral neuropathy being the most common type. As I said, we see it in type 1 and type 2 diabetes. In type 1 diabetes, after 10 years duration of having type 1, it's not uncommon to develop peripheral neuropathy. Slightly different in type 2 diabetes, where indeed we do see it after a duration, but actually we can even see it early on in type 2 diabetes, sometimes even as a presenting feature before somebody has even got an official diagnosis, with about 10 to 15% of people newly diagnosed with type 2 diabetes having some element of peripheral neuropathy. The unfortunate situation is that at an early stage, peripheral neuropathy may be asymptomatic. Patients may not have even realised that they're losing that sensation in their feet. And here comes our role, doesn't it? It's in screening and picking up those peripheral neuropathies early on and stopping any problems arising in the first place. We're going to hear from the fantastic Scott Corley shortly, but actually we don't really want our patients with diabetes to ever have to go and see our podiatry colleagues, because we want to try and prevent any issues arising. Next one, please. If you just click through, that's lovely. So in terms of risk factors, how we might prevent peripheral neuropathy occurring, well, actually, they're the same sort of risk factors that we work really hard to control for many reasons in our patients living with diabetes. Glycemic control, dyslipidemia, hypertension, smoking, and of course a number of unmodifiable risk factors in terms of age and duration of diabetes. We often see microvascular complications of diabetes occurring together in patients. So if somebody develops diabetic retinopathy or diabetic kidney disease, we may well see that diabetic peripheral neuropathy occurs hand in hand with these other microvascular complications. This gives us some clues in terms of which patients might be at greatest risk. And of course, it's vital that we identify this early, because we know that diabetic foot ulcer and indeed amputation has a massive impact on our patients in terms of both quality and quantity of life, as well as, of course, a significant burden on the healthcare system in terms of those expensive hospital admissions, multiple clinic visits for ulcer healing, and so on and so forth. Next slide, please. In terms of the relationship with glycemic control, something I spend most of my life talking about, and in terms of my education to primary care, is about how we can improve glycemic control. And Julia's already showed us that that's challenging to achieve those HbA1c targets. Actually, in terms of peripheral neuropathy, glucose control isn't always the strongest thing that we can do to prevent that peripheral neuropathy occurring. In type 1 diabetes, the relationship is a little clearer, with the famous studies such as the DCCT trial showing that actually in more intensively controlled glycemic control in people with type 1 diabetes, yes, we can significantly reduce peripheral neuropathy. Actually, in type 2 diabetes, which is really a lot more complex in terms of its pathophysiology, we see that actually reducing HbA1c has less of an impact on trying to prevent peripheral neuropathy occurring. And the famous studies such as the ACCORD study and UK-PDS, which I'm sure many of you will have heard of, which looked at intensive glycemic control and complications associated with type 2 diabetes, showed a more modest relationship with tight glycemic control and reductions in peripheral neuropathy in the longer term. So type 2 diabetes is a lot more complex, there's a lot more going on. Often people may have been hyperglycemic for some years prior to actually receiving the diagnosis of type 2 diabetes. They're often much more complex with a lot of comorbidities. It's pretty rare we see someone with type 2 diabetes who doesn't have another comorbidity, be it hypertension, hyperlipidemia, COPD, and so on and so forth, cardiovascular disease. So a lot more complex in terms of what we can do, but we know that trying to manage all of these risk factors, be it glucose control, be it hypertension, hyperlipidemia, is important and will help in the prevention arena in terms of peripheral neuropathy. But what we really need to do is pick it up early. Have the next slide, please. So we need to try and find it early. And of course, one of the key roles in primary care is in terms of screening. So we know, and Julia already showed us briefly, the data around the essential care processes, all of those procedures that anybody living with diabetes should have done at least annually. And one of those is the foot check. So what do we do in primary care? Well, we always ask about feet. So at that diabetes review, we're going to ask about feet. Are you having any issues with your feet? Have you noticed any changes? So on and so forth. But as I said, peripheral neuropathy is often asymptomatic at the early stage. So that examination, that taking off the shoes and socks is really valuable. Having a look at somebody's foot and then as an absolute minimum, using a monofilament to examine and look for signs of early peripheral neuropathy is something everybody should be having done. Ideally, we want to use other methods as well to improve sensitivity and specificity, but as a bare minimum, looking at somebody's feet and examining them with a 10-gram monofilament should be done at least annually. Next one, please. When we've done that, then we can rate somebody's foot in terms of its risk. So be that low risk, moderate, high or active. And then we follow, and I know Scott's going to talk more about the foot pathway later on, so I'm not going to go into the detail. We decide whether that person should be looked after in primary care or indeed should be referred on to our podiatry colleagues, and with what degree of urgency. Next slide, please. A lot of our role, I think, in primary care needs to be around education as well. Be that making sure that we are up to date as healthcare practitioners, but also that our patients understand the importance of good foot care. So when we're seeing patients, we need to make sure that we need to be looking at your feet, particularly at the time of diagnosis of type 2 diabetes, but also beyond, reminding patients of the importance of good foot care. And I know Scott, I'm sure, will mention the value of self-activation amongst patients in terms of foot care. So it's good to have really good resources that we can recommend. The Diabetes UK website is always excellent for resources for patients. They've got a superb page called What to Expect at Your Foot Check, how to reduce your risk of foot disease and so on. And that's often a really good resource to signpost patients towards. One really important aspect, I think, is to know how to work with our podiatry colleagues. And hopefully Scott will back me up on this, but often when I do talk to our podiatry colleagues, they often feel that in primary care, we tend to hold on to patients with foot issues for too long. And actually, our podiatry colleagues often want to see those patients with new foot issues in diabetes more quickly. So it's really a really valuable quality improvement project, just to make sure you know how to get a patient seen by your podiatry colleagues urgently, because it's always, isn't it? It'll be this afternoon, it'll be a Friday afternoon at 4 o'clock. You've got a patient with a new diabetic foot problem that needs to be seen urgently. Do you know the pathway? Do you know how to access that care? So it's a lovely quality improvement project for our primary care colleagues to take away, to actually make sure that everybody is aware of how to make those referrals, of how to get a patient seen promptly when appropriate. And in terms of our own education, I think as a minimum, we should make sure that all of our healthcare team are aware of how to do a good foot examination and how to act on the results as well. And something I often recommend is the diabetes frame modules. These are totally free online modules that can be completed. My healthcare assistant has completed these. We've trained our healthcare assistant now to do foot checks. She's brilliant at them. And she completed these diabetes frame online modules. There's a number of them there aimed at various different healthcare practitioners that I well recommend signposting your practice nursing staff towards, healthcare assistants, district nurses, and indeed nursing home, residential home staff as well. Next one, please. Oh, the dreaded C word. So what has been the impact on COVID? Of COVID rather? Well, as we all know, GPs are sat at home not doing anything. No, absolutely not. I can absolutely refute that. I have not missed a single day in the practice since COVID began. But yes, there has been a reduction in face-to-face reviews. Certainly during the initial wave, there was a reduction in face-to-face diabetes reviews. As we move forwards, I think many practices now have moved towards a two-part review for our diabetes reviews, based very much on the RCGP Year of Care model. This is certainly something that we have now taken up in our local practice. So the patient will come in for a single visit. They see my healthcare assistant. They have the data gathering done. So blood pressure taken, bloods taken for HbA1c, lipids, and so on. And they have their feet examined. Who should that be by? My healthcare assistant does it. Is there a role for your clinical pharmacist? Our clinical pharmacists are doing a lot of our diabetes reviews on our housebound patients now, for example. Does that clinical pharmacist have the ability to do a quick foot check as well? Then the second appointment is often remote. So either myself or the practice nurse will ring that patient and go through results, discuss things online, signpost towards good resources, make any changes towards treatment. One silver lining that's really come out of COVID for me in terms of diabetes reviews in primary care is the use of pre-review questionnaires. So I now send out my patients before they come for their review a questionnaire. We ask some really nice open questions on that. So for example, how do you feel you're getting on with your diabetes at the moment? How are you getting on with your medication? And how are you getting on with your diet and your physical activity levels? It also gives us an opportunity to record some data. So we can ask patients to do some home blood pressure readings and jot them down before the review, some home blood glucose testing and so on, if appropriate. And, you know, it has been fantastic, and it's definitely something that we will take forwards because it allows us to really prioritise that discussion to the patient's priorities, what is really bothering them, and it allows us to do some home data gathering as well. And foot care comes into that as well. And certainly during COVID, we've been utilising the Diabetes UK Touch the Toes test, which essentially is a way to do a home foot check, which is well validated. So I'll just have the next slide, please. This is my example of just the one that I wrote for our own practice. And I know I've sent this out to loads of practices across Wales already, and I'm more than happy to do so. But we send this out, and as you say on the left there, those open questions, how do you feel you're getting on with your diabetes at the moment and so on. And on the right hand side, that ability to be able to record some home data, including potentially a home foot check, or at least the ability to record any issues that patients may have had with their feet since their last review. Next one, please. So this is the Diabetes Touch Your Toes test. This is based on something called the Ipswich test, which was actually designed to improve foot checks when patients are admitted to hospital. Patients living with diabetes are admitted to hospital. And essentially it's a well-validated test without the need for any equipment. And actually, when we look at the trials around this, the sensitivity and specificity is very much on a par with monofilament testing. And it's been promoted by Diabetes UK as the Touch the Toes test. So you can signpost patients towards this. We can text out using AccuRx or your text message system a link towards this website on Diabetes UK about how they can accurately do a test at home. And of course, if that then flags up issues, we need to be seeing those feet promptly to see whether there is any intervention that may be required. Next one, please. This is a fantastic resource if you haven't seen it. Declaration of interest. I do sit on the Primary Care Diabetes Society committee, but there's some fabulous resources from from Primary Care Diabetes Society, totally free to access on their website. And this is one called How to Undertake a Remote Diabetes Review. There's some superb resources there, checklists to go through, signposting towards all the good things that we can send out to patients in terms of safety netting and educational resources as well. So do have a little look at Diabetes on the Net for lots of really good resources to support us out there in primary care. I'm going to flick through this slide because I know I'm running out of time, always trying to talk about too many things as normal. But remember, of course, the importance of equality of care. If we're thinking about remote diabetes reviews, it's all very well saying, oh, we can text out the link to Diabetes UK and, you know, patients will ring us if they've got a concern with their feet. But of course, we must always remember that it's those patients who may be at the most need of our care that do not contact us in that particular way. How can we ensure equality of care as we go forward and target those patients most at risk? Next one, please. So finally, before I stop talking, I just want to mention about easy ways that we can access our own practice data. So we know that when we had QOF around diabetes, it was really easy, wasn't it, to access how we were getting on a day-to-day live basis. A bit more tricky now. Yes, we can write searches on Vision or EMIS, but that can be really tricky and variable as well in terms of our ability to do that. Certainly, I find it very challenging. One thing we have got is access to the National Diabetes Audit data that Julia briefly showed us. And one way you can easily see that in a really nice sort of pictorial way is on Primary Care Information Portal. Everyone's got access to this. Just go onto the intranet and search for PKIP or Primary Care Information Portal, and you can get access on your NHS Wales computer. There's also an Audit Plus dashboard with the NDA data supported on it, which you can access via Informatica, and I'm going to talk very briefly about that a bit more in a second. Here we've got the completion of foot checks in this very pictorial fashion from the Primary Care Information Portal. Now, we haven't got the most recent year. You can see this only goes up to 2018-19 at the moment, but it will be updated shortly. But you can see on the left there, you've got practice level, so how well we've been doing foot checks over the last 4 years in my medical centre. And I like to think we're really good at Woodlands, but you can see it's been on the decline. Then you've got your cluster, you've got your health board, and on the right there, you've got all Wales. So a lovely way to see how you're getting on compared to your cluster, compared to your health board, and indeed across Wales. And we can see that annual foot checks has been falling at all levels. And we know that Julia showed us the most recent data as well from 1920. It has indeed gone down again. Next one, please. How does this compare to everything else? Well, this is a number of people having all 8 care processes completed, which has actually gone down, but probably stabilised, but very, very challenging. You can see that under 50% of people living with type 2 diabetes, and that first graph was just for type 2 diabetes as well, have had all 8 essential care processes completed. Next one, please. And how does having foot checks compare to the other essential care processes? So this is the 18-19 data for people with type 2 diabetes across Wales. You can see the least well completed essential care process is urine albumin. That's a whole other presentation that I could happily do at any time in terms of how we might improve our urinary albumin pickup rates. But you can see the next least well completed essential care process is indeed foot surveillance. So definitely some areas for improvement here. Next one, please. Why then? So why is foot screening on the fall in primary care? I think there's a number of reasons potentially why that might be, and I'd welcome your comments really. Certainly, I think that the lack of QOF is driven some degree to this. We know, love it or hate it, QOF was always that tick box that you had to remember to tick. Oh gosh, I've got another 35 patients, got to have their foot checks done by March, let's get on and do them. We don't really have that drive now. So I do think that has definitely had an impact. We know we're under massive demand, don't we? Type 2 diabetes is rising. We've never been so busy in primary care as we are now. We're under great stress and demand is on the increase. I think there is some reduced awareness. I think there is that role for education, both amongst patients and healthcare practitioners. And we know also that we're all looking after really complicated patients now, a lot of multimorbidity, a lot of frailty as well, housebound complex patients. And it can be difficult sometimes then for those patients to access healthcare properly, and for us to provide that really good approach, making sure that they are having their essential care processes reviewed every year, including foot screening. And my last slide, please. She says, hopefully it is the last one. Thank you. Just want to briefly mention an ability hopefully to access your data more easily going forward. So I've been in the background busily expanding the Audit Plus module for diabetes. So currently you've got access on Audit Plus to your national diabetes audit data, but I wanted to expand that to easily be able to identify your highest risk patients. So we're going to be able to go onto your Audit Plus for the diabetes dashboard, and for example, you want to see all of your patients with an HbA1c over 100 millimoles per mole. You'll just be able to click on that and get your patient list for those patients with the highest A1Cs. We're going to include things like frailty on this Audit Plus module, so you'll be able to easily identify your patients living with frailty who may be overtreated. Do they need to have some de-prescribing performed? We'll be able to see, in terms of prescribing data, which patients are on insulin, how many patients have you got on insulin, how many have you got on sulfonylureas, and so on and so forth. And I'm really hoping that this is going to be a big deal in terms of how we can access our patients at highest risk in diabetes and drive for some improved care. So it's on its way to us via Informatica. You'll be able to access this certainly by the beginning of 2022, but hopefully certainly before the end of 2021 is my aim. And there'll be lots of how-to guides and lots of information and ideas for you coming along with that. And my last one, please. So finally, before I hand over to Scott, we have a vital role in primary care around foot care, don't we? Around the screening and identifying issues early, around education and prompt referral on where indicated. We've seen the number of people receiving foot screening has declined year on year, a number of potential reasons for that. So have a look at Primary Care Information Portal, those really pretty graphs, and think about going forwards using that Audit Plus module to identify patients who might be at highest risk, those with the highest A1Cs, those with active diabetic foot issues, and think about how we might be able to improve our own performance using, for example, nudge text to get people through the door, and using that multidisciplinary team, including our healthcare assistants, our clinical pharmacists, and of course, our podiatrists. So on that note, I will hand over to Scott. Sorry for running over very slightly, Scott.
Thank you, Sarah. That's fantastic. Thank you for inviting me this morning. It's a really exciting time to be part of this presentation, because for those who don't know, it is Diabetic Foot International Week. And of course, we've also got World Diabetes Day as well. And it's great that we're all here as part of a multidisciplinary team, really, to talk about the value of diabetic foot disease and the awful consequences and debilitating conditions in terms of mortality, but also cost to the NHS. For those who are not aware of it, is £1 in every £150 is spent on diabetic foot disease and amputation. A vast amount of money is spent on it. It's good to hear the positive steps that we've just mentioned. We just heard from Sarah and the rest of the colleagues, but we need to realise we need to change to protect and sustain our services in the future. And this requires clinicians and patients to have shared responsibility to ensure its existence. I like this quote I saw once, and it said, "We need to remember the NHS is free about the point of need, but not free from responsibility." And I think that's very, very true. And I think we should all remember that. So what will I be doing? Well, I'll be discussing the existing pathways and why we need to change, and what we've done across Wales to ensure we are providing not just value-based healthcare, but also person-centred care as well. And I think that's very important. But before I start talking about the pathways, I see we got the first slide up. We've never had so much data coming through about diabetic foot disease now, so it's absolutely marvellous. So I'm absolutely delighted to have Diva. Mind you, I'm not sure if my colleagues did because they couldn't get me off the laptop. I've been scrutinising this, but we also participate in the National Diabetic Foot Audit as well. But what we've always failed in Wales is we've failed to be able to do root cause analysis to any real meaningful way. And I'll just talk about our colleagues down in Swansea Bay who actually have done that. Only because they're so time consuming, gathering the information, having all the people together in one place. Diva has the potential to collect this data. So it's an exciting time. We could use this for root cause analysis. But we must remember that actually the majority of wounds are managed in the podiatry. And 80% of all amputations are preceded by a foot ulcer. So the big problem we have is that we don't have very good integrated systems between podiatry and primary care and secondary care. And I think just to call out for the community care colleagues here, a lot of great work is going on in the community. We mustn't be missed. You know, we have primary care and secondary care, but don't forget there's community which is holding this together as well. We now have the other opportunity. We have Wisdom, which is a diabetes record card. This was made predominantly for secondary care, but now I hear they are using it down in down in community care as well. And that will hold NDFA data, and we'll also have the podiatry participating on that as well. So again, we have a system now which will collect an awful lot more data that we can start using it. So the National Diabetic Foot Audit, well, all the UHBs across Wales participate. But we only have an ascertainment rate of about 10 to 20%, and nationally I think it's about 20% anyway. That was previously because we weren't able to participate patients unless they gave consent. And in the busy clinic, it's very difficult to get consent from patients whilst you're also trying to treat them. But that has now gone. We also had suspension during the COVID crisis, but now we're up and running again. So hopefully we'll start getting some meaningful numbers in. Because at 20% it doesn't tell you an awful lot. But I can compare the DIVA with the National Diabetic Foot Audit, and this gives us a few interesting characteristics. The average age of ulceration and amputation is 66 years, and with 74 to 76% of them being males. The NDFA shows us that the average duration of diabetes is 16 years. And 35% of these patients are from the lowest fifth of the deprived areas in Wales. The average BMI is 31, and 40% being smokers or ex-smokers. Now, as a clinician, that doesn't surprise me. That's what we see day in, day out. But actually, we now have some meaningful data to actually back this up. So could you target a group? Could you target the male diagnosed in the early 50s, smokers or ex-smoked from deprived areas, and again, potential low social economic employment. So we're talking about security guards, hospitality, and these types. A lot of people who are on 0-hour contracts, and I'll talk about that later as well. Just to note that we only had one health board has really carried out a really good, meaningful root cause analysis on their amputations, and that was carried out by Swansea down in 2015, and they used really robust methodology, and they found that delayed assessment, diagnosis, and low levels of patient activation, and that's confidence, knowledge, and skills, were primarily modifiable contributory factors in nearly half of the preventable lower limb cases. So that is very, very interesting as well. So anyway, just from the data, we can see the complexity of managing foot disease and how it requires a whole system approach. So if we just go back onto the next slide now, sorry, I just saw you coming up there, and it's what Sarah alluded to earlier. This is called the Put and Feet First pathway, and this has been around for quite a while now. And I just want to talk about this. Here we have it's well recognised. It's been around for a while. And it involves assessing the patient's neuropathy, arterial disease, and podiatric ailments, as Sarah said earlier. And it gives them a risk stratification score to potential to ulceration. The level goes from low, moderate, high to active. Really active isn't so much as a risk classification, it's actually because you've already got the wound. It then goes on to direct care required to manage those in each stratification group. Evidence has previously shown that from the SkyDC, who's got the most robust data, that 70% of these patients are low risk and would remain in primary care. 20% would be moderate risk, and 4 to 8% were high risk, and 1 to 4% have an active foot disease. And these would be seen in your foot protection teams and multidisciplinary foot teams. When we talk about foot protection teams, we're normally talking about the podiatrist and orthotic services with our primary care colleagues. And then multidisciplinary team, we start talking about the podiatry and our consultants and surgeons, etc. The problem with the pathway as it exists, it assumes risk based purely on what is clinical hazards and assumes the path one size fits all. It also doesn't involve what role the patients can have in reducing their risk to ulceration, and could be actually demotivating. If whatever you do, you remain the same risk. Looking at the pathway as it stands, it could be said that it's paternalistic and disempowering. If we look at the actions in the moderate risk alone, you can see they actually say on that you should be seen within 1 to 2 weeks if there's immediate concern, and then 6 weeks if there's no immediate concern, and every 3 to 6 months. And then if you look at the high risk, it says 1 to 2 weeks if there's a concern, and then 1 to 2 months thereafter. But this has put a lot of pressure on the services to see these patients, and you would have to question why if they don't have any clinical need, or is it just for surveillance, which the patient could do themselves, of course, if they were activated. Also, it has the impact of reducing capacity, so when patients do have a foot crisis, they can't be seen as urgent. This clearly doesn't fit in with the principles of prudent healthcare, so what have we done about this? Well, back in 2017, the then Workforce Education and Development Services, along with the NHS organisations, undertook some work to introduce and deliver a behavioural science approach to clinical decision making. This meant funding a pathway project in the UHB. I was lucky enough to secure the only one on a national scale, and it was part of the National Diabetic Foot Network. This was delivered by Kate Malcolmas, who was a consultant in ethical, effective practice. It was clear we needed to review the current pathway and ensure patients were at the centre of what we were trying to achieve, as they are their greatest assets to success. Over the past few years at biannual diabetic foot meeting, we worked on these changes, and my colleague David Hughes was then instrumental in developing and finalising the new prudent pathway prevention and diabetes-related foot crisis towards the end of 2019. But then, of course, we had the dreaded C hit us. So we weren't able to implement it. But I think what it did, it refocused us to why we were trying to achieve this, because we know the patients who did best during the COVID crisis are those who were actually activated to self-care. So it really reaffirms what we were trying to do. Can we have the next slide, please? So here's the new pathway. So if we just look at it from left to right, we still assess for neuropathy and arterial disease and other factors, but these are clinical hazards. We then use alongside their activation hazard based on the individual's level of knowledge, skills, importance and confidence to self-manage, and as gauge as equal parties in their health. This then gives us the true risk to crisis and identifies the needs. I like to try to keep it fairly simple. If you were driving a car and you saw a hairpin sign going around a bend, is that a hazard or a risk? Or is it a hazard? It only becomes a risk if you don't slow down. And it's very similar there. Patients need to take the responsibilities. So how do we capture the patient's activation levels? Well, initially we were going to use a questionnaire, which I'll show you on the next slide, and it's something we'll be using again. But in the meantime, to support this new model, we've been able to secure funding from the All Wales Diabetes Implementation Group to purchase the patient's activation measure. This is known as the PAMS license. And it comes from Insignia, which is a company in America. And the PAMS is a 13-item survey that assesses a person's underlying knowledge, skills and confidence to manage their own health. This puts them into 4 levels. Level 1, disengaged and overwhelming. This is where my doctor is in charge of my health. Level 2, becoming aware but still struggling, and their perspective is I could be doing more. And level 3, taking action, I am part of my healthcare team. And then level 4 would put I'm my own advocate. These levels are derived by inputting the data into the Flourish Insignia web-based system, which not only identifies the level, but indicates what coaching for activation would help to increase their activation levels. This questionnaire can actually be delivered via email and is also accessible for carers and for parents as well. This is not only a great opportunity to support the patient's activation, but also increase the knowledge, skills and confidence of the clinicians in the delivery of this new model. This new pathway has been taken to many professional groups because obviously we're doing a significant change here. We're taking it to the Welsh Endocrinology Diabetes Society, National Service Advisory Group for Diabetes, the National Orthotics and Podiatry Service Advisory Group, Diabetes UK, but the most important group, the All Wales Diabetes Patient Reference Group, and they are quite keen to be partners in this as well. Next slide, please. This is just the question that I talked about that we were originally going to use before we had the license. And again, we have to acknowledge our friends down in Swansea Bay, Podiatry Service. This has been developed by them and we just slightly modified that. I'm sorry it hasn't come out very clear on that. If I just tell you what the what questions mean. Question 1 says, please tell us what you would like to talk about today. And question 2 would be, what are your goals? And then what we would ask them is, before you see the podiatrist today, how important do you feel it is that you do things at home to help you achieve your own goals? And then before you see the podiatrist today, how confident do you feel about what you might be able to do yourself to achieve your goals? Then they would see the podiatrist, and then they would have the second page completed. And again, you would ask, did the podiatrist discuss what you feel is important to you? Did the podiatrist discuss your goals? And did you achieve what you hope to achieve in today's visit with the podiatrist? And again, we would reiterate, and we'll go back over the importance and confidence scores again to see where they are on that. So that's a very exciting piece of work, and we will be using that again once we've used up the Insignia's license. We have it for 1 year, and we're hoping to get it for a second year, but obviously there's a cost implication to continue doing that. Can we have the next slide, please? Okay, so what happens when a patient comes into crisis? Well, this is a diabetic foot ulcer pathway. I know it looks quite busy and it's very clinical, but it does direct care, and we use it using a wound classification system. We know if you use tools, they need to be simple, standardized and objective. We use the Texas wound classification over SIMBAD, which is used for the NTFA, as the SIMBAD is an audit tool rather than a communication tool. The Texas indicates where the wound has ischemia, has infection, or both, and the depth of the wound. This allows us to ensure the right person with the right skills manages the patients. If we look at the pathway, you can see that the non-complicated and the compromised are seen within the foot protection team, closer to home in the community. This has only been achievable through the successional planning we have, a very successful planning within the podiatry service, and we also work very, very closely with our primary care colleagues. But it should be noted that the podiatrists also support the multidisciplinary foot team as we provide a step up and step down facility. As the wound presentation becomes more complex, the involvement of the multidisciplinary team is normally required. But again, within this pathway is the ability to direct the right specialist to the multidisciplinary team. So again, ensuring effective and efficient use of our resources. The last part is the mission of the severely complicated. This has over the years been concerns around the coordination of care once patients get admitted, but there's a clear guidance that all patients admitted to hospital should be under a consultant, and that care transferred within 24 hours to a named consultant if admitted due to foot disease, who will manage their care. This coordination is now more important than ever as we have centralised and vascular services across Wales. So we have hubs and spokes, and we need to make sure that we repatriate these people, these patients, and it'll be very, very fundamental to ensure that we have a good flow system. Could I have the next slide, please? Okay. Okay, I'm not sure if it's going to come back up the slide. Okay, this slide is looking at actual management of the patient actually when it comes down to clinical, and it looks at what we call the VIP approach. And this is very much looking at what the vascular state is and what we should be doing, and also the infection state as well. Apologies if it's not coming up. I think it might be in a minute. Yes, here we are. So this is the All Wales Foot Ulceration Standards of Care. It's a VIP approach, and this is it's quite easy. We expect everyone to remember this, the VIP approach. So when they actually see a patient, they all carry out the vascular state. One, carry out a vascular assessment, consider clinical features, subject questionings, identify our claudication or rest pain. And this is a standard we expect everyone now who manages a diabetic foot wound. Infection, is there evidence of infection? What are the clinical features? Let's make sure we get differential diagnosis just in case they say it's an infection when actually it's a Charcot foot. And we all work with antimicrobial dressings, guidelines, and same for your antibiotics as well. The last one is pressure, and I'll just talk about that in a minute, but obviously we need to make sure that we've got metabolic control, and we need to make sure that everything we use is evidence-based. Pressure is an interesting intervention when you consider what matters to patients. We know gold standard is putting patients who've got neuropathic foot ulcers in below knee casts. But as previously identified, some of these would be low economic workers on 0-hour contracts, or maybe carers, and there might be a host of other reasons. And it's important we understand as clinicians what matters to them. And in this case, it might not be how quick we can heal the wound, but can we still heal it whilst they can carry on doing the activities they need to be doing. But previously we would have said that that patient was non-compliant, and mainly because we're all worried about our healing rates. But we must remember one size doesn't fit all. Next slide, please. Okay, so this is the last slide. We obviously need to measure what we are doing, but this is where we've taken some of the documents to direct our care. King's Fund, we're looking at patient activation. It was released, Prudent Healthcare and Patient Activation, in 2015 in Wales. And obviously we participate in these audits, and now of course we've got DIVA, and these are the things, the matrices that we'll be looking to try to measure. And I just really want to finish off on one thing, really, is one is that there's a new best practice statement being released by Wounds UK and the FUK this week. It's best practice statement. It is called Care of the Person with Diabetes and Lower Limb Ulcers. And it very much focuses on very much of the stuff that we're already trying to achieve in Wales. And I'd just like to go back to that original quote when I talked about responsibility. And I picked this up as well when I was looking at it. And this was put nicely by Gillian Clark, who's the national poet for Wales, speaking at the Prudent Healthcare Conference in July 2015. And she said, "We need passion and belief today to help save our NHS. It is everybody's favourite organisation. We all believe in it. It must not die. And it's not just the health experts that will save it. It's me, my children, my grandchildren, my neighbours, my community, my friends." And I think that put it quite nicely. I think we need to make sure that we're all in this together. So I'll just finish there. Thank you. Julia, I think it's back to you.
Thank you so much, Scott. Could I just take a second to say Scott is fresh from Windsor Castle, and a big congratulations to him for receiving his MBE. Very well deserved.
Thank you very much.
I'm going to talk a little bit about hospital care and the next steps. And I won't take too long because I know we're a little over time and we want to leave time for questions. Next slide, please. We've already said that there are a lot of foot ulcers in England and Wales. There are a lot of amputations, unfortunately, occurring in England and Wales every year. We know from the National Confidential Inquiry into Patient Outcome and Death review that was done in 2014 that the 30-day mortality of an amputation is 12%. So let's have a little look at the figures in Wales. Next slide, please. This is that National Confidential Inquiry. It showed more than half the people who had an amputation have diabetes. The average age of amputation in diabetes was 68 years. And I think Scott's already told us that in Wales, it's 66 years. Next slide, please. What this confidential inquiry showed us was that if we look at the outcomes at 30 days, 65% of people are discharged in a home or in a care home, 20% of people are in hospital, and 12% of people have died at 30 days. Next slide, please. The inquiry also showed us that less than half of the services looked at displayed good practice. The rest of the services all had some room for improvement. Next slide, please. This modelling looks at what factors contribute the most to amputation, and you can see that the number one factor is ischemia, poor blood supply. The area of the ulcer is the next important factor, the site, if the ulcer is on the hind foot, the age of the patient, the smoking status, renal replacement, etc. Next slide, please. So if we look at the DIVA data, we can see this is 2018 to 2019. There were 641 amputations in Wales, and we can look at this across health boards and see that there's a particular health board where there are more amputations than others, and we have the ability now to look at it at cluster level and at GP practice level, so we can see if there's a particular area that we need to focus on. The inpatient mortality in Wales is 5% during the admission, but it's even greater after discharge from hospital. And we know that mortality is greater if you're admitted as an emergency compared to if you're admitted as an elective patient. Next slide, please. This is just looking at deprivation in Wales. So we can see that the highest amputation rate is not where the area of greatest deprivation is. Next slide, please. When we look at smoking in Wales, we can see that smoking is highest in our areas of interest. And this is interesting, particularly as we saw that ischemia was such a powerful factor. Next slide, please. If we look at the mortality figures, they do vary across Wales. What is interesting is that the overall mortality is highest in Betsy Cadwallader, but if you look at the inpatient mortality, it's highest in Cardiff and Vale. But then if we look at the mortality post-discharge, Cardiff and Vale come really low down compared to the other health boards. And this is starting to say, is there something about the pathway that we need to get right? Is there an optimal length of stay? Is there an optimal set of processes when patients are in hospital having an amputation that reduce mortality? We also know that we have to correct between provider and commissioner, because there are some health boards where the vascular services are centralised. People are going across borders into other health boards to have their procedures. Next slide, please. We know that there are large differences in the length of stay for health boards, for hospitals, and there are also large differences in admission costs. There's going to be a lot of things that affect length of stay, for example, timeliness of procedures, complications, the availability of rehab facilities, the availability of social services, and that's something that we need to look at in Wales. Next slide, please. So putting our practice to data has shown us that we've got a geographical area of high amputation compared to the rest of Wales. We can see a higher correlation with smoking than with deprivation, which is interesting because I did expect at the start of this that deprivation would be one of the key factors. We can see extremely high admission costs for people who are having amputations in Wales, and very variable lengths of admission and very variable costs. And we've got certain things associated with higher mortality, such as emergency admissions. We've seen an opportunity to prevent diabetes. We've seen an opportunity missed to screen people's feet and protect their feet. And we've also seen an opportunity in the whole pathway for patient empowerment. Next slide, please. So what are the next steps? So we need to put our data into knowledge, and we need to put our knowledge into practice. What we know is that we may need a different service in some areas to bring about equality. Doing the same thing in all areas is not necessarily going to bring about equality, and we have to have a little think about what this looks like. We know that the speed of intervention is often important in foot ulcers, how quickly a patient can get to the MDT, how quickly a patient can get to the surgeon. And this means that we need innovative pathways. We can't use our traditional referral systems. And sometimes these things are going to be uncomfortable to us. We're out of control. We're going to put the patient in the driving seat and let them get to the right place at the right time, empower them to do so. We need to optimise inpatient care in line with the National Confidential Inquiry recommendations. It's been out now 7 years. We need to make sure that all our inpatient facilities are abiding by the recommendations. We need to optimise prehab, rehab, and specialist teams looking after people in hospital. We know our biggest challenge in diabetes is moving the resources upstream to prevent the downstream problems. It's not just foot problems, this is for everything. We need to get the resources focused at the start of the patient journey to prevent all these problems later on in the patient journey. And that is difficult because it is difficult to move money in that way. And we also need to examine differences that we're seeing in our system in things like length of stay, costs and outcomes to get an optimal pathway. So I'm going to leave it there and thank you all for your attention and invite questions to our panel.
Wow, that's great. Thank you very much, Julia. And really thank you to the panel and to share. Really, I hope for all of you listening, you've enjoyed hearing about the various stages of his work, how it's developed over the last 12 months, and certainly the progression in the many kind of intervention areas across the patient pathway that have been described today. We do have some questions which I will try and help guide the fine team at Value in Health, so we're not jumping around the screen too much. But the first I am going to ask to each of you, so I'll probably call you out in order, because you've had a question in from Jonathan Morgan, which is, how do the panel members see innovation and technology supporting all of this fantastic work taking place? So if I can ask Amrita to come in on that first, and I'll run through the panel.
Hi, thank you for the question. I think it's a great question, and it's so pertinent at the moment with all of the developments that we've seen in the pandemic. I think from a prevention perspective, innovation and technology around consultations, around measurement of weight, and how we can think about data joining up digitally at the back end, but also about how patients can engage at the front end with us through different means. One of the really interesting observations from NHS England has been that potentially some of those digital methods and virtual methods might actually be more appealing to younger people, and that's some of the evidence that they found. And so I think that's a really important consideration. But at the same time, we're aware of some of the challenges. We're aware of digital inequalities. We're aware of the access issues that some people have, and how that might actually pose challenges to objective data measurement. So I think it's really exciting, and there's lots of potential, and we just have to sort of mitigate for any potential unwanted consequences, but lots of potential there.
That's great, thank you, Amrita. Sarah, can I come to you, because I know you talked about technology and accessibility and not really making sure we've got various options for contacting patients. So grateful for your thoughts on this.
Yeah, I think as we all have in primary care, we've really learned about the use of remote consulting and technology over this last 18 months by force rather than anything. But, we know that COVID has some good things have come as well, haven't they, that we will take forward. And certainly the use of technology in primary care is one of those. So things like people using video consultations, for example, people using more in the way of text messaging. AccuRx has been great for being able to send out links to patients. So, instead of we know that written information, safety netting and so on is a vital part of diabetes care, but actually instead of having paper leaflets and things that just get flung in the bin or in the car park normally on the way out, we can actually text through links to reliable sources of information for patients, which I think has a very valuable role around education. And there's new ways of learning. So for example, a really valuable resource in Wales that I'd like to mention are the Pocket Medic videos. So these have been around, these are pre-COVID actually, but these are short, patient-orientated films, and we can text out the link for patients to watch Pocket Medic videos. There's a range of them there, all around prevention, healthy eating in diabetes, what is diabetes, and now there's a number available in various different languages as well. Patients love learning things by videos. My children are never off YouTube. That is the way that people learn things now, isn't it? And so Pocket Medic videos have been a great step forward, I think, and certainly using technology and innovation in improving patient education, I think is very valuable. But you're right, we need to offer the whole package, and for some patients that will not be an appropriate way to access healthcare or access education. So we need to be able to offer a little bit of everything.
That's great, thank you. And Scott, you also touched on this. Is there anything you'd like to add really to the question?
Yeah, it's just that we've tried some of this new innovation and digital specifically around wounds, obviously, because you can imagine these patients through the COVID crisis did not want to come into the hospital environment at all. And we actually used AA, and we had some real funny experiences with patients trying to show us their wound with their phone, but it showed a willingness to want to try. And I think that's something we need to work on. Now, whether it was right for all patients, we're still reviewing that, because there's nothing like seeing whether the foot's hot or cold, and you don't quite get that through digitalisation. But we have learned from our colleagues up in Scotland, who obviously got large geographical areas where they can't get access into Teams. And we've actually thought about, can we use our empty team meetings and actually have a podiatrist with a patient outside, who could actually then film in. So there's really great potential, but I think we need to just map it out where we are now. And now as we start to get our clinics back up and running, we need to try to bring it all together and see where it does fit in. But it certainly does fit in the digitalisation side, yes. Great,
thank you. And we're having a lovely flurry of questions, so I'm very grateful to everybody attending today. So I'm going to try and squeeze in 2 more if I can. So Rita, can I ask you, we've had a question, how do you think we could further educate the public in prevention and people living with diabetes to manage their condition?
Thanks. Yeah, a great question again. I think that one of the really key points of this is, particularly in the prevention space, how related this work is to the broader obesity prevention agenda, and there's an awful lot happening around the Healthy Weight, Healthy Wales strategy that Welsh Government's developed, and taking that delivery plan forward. And I think that a large part of that is the sort of communications and engagement with the public, to really recognise the risks to their health and the support that's available to help them to get to a healthier weight. So I think it really is very much linked to that. But in addition, I think the resources that Sarah was highlighting, particularly around diabetes and also diabetes prevention, are relevant as well, and just being able to take advantage of the All Wales Diabetes Prevention Programme to increase the awareness of those resources as well. Thanks.
That's great, thank you. And then I'm going to ask this one to Julia, if I may. In addition to the services offered by the NHS, what organisations, services and professions also could be and need to be and perhaps should be involved to reduce the level of amputations?
Yeah, I mean, we've seen from the pathway how complex it is. You know, we've seen things like stopping smoking is important, patient engagement is important. And then it involves really every single bit of the pathway and trying to get the pathway right. I mean, one of the things that is very important in diabetes is patient empowerment and education. And one of the things that we're trying to push forward in future, any future diabetes planning, is that patient empowerment and self-management is given equal weight to any medical services. Because we haven't been good as an NHS at doing this. We've been far better at providing medical care for people, but this is something that, you know, we're really trying to focus on now. So it's where do you stop, really?
That's great. That's great. Thank you very much. And then just to answer one last question before we say thank you and close the session, we've been asked about access to the Atlas. So the Atlas is available through the information in the Value in Health newsletter and on the Value in Health site. There's also a vault for those who are familiar in NHS Wales, and you can gain access to the Atlas. We are working to develop some videos and some key analysis that will also be available to all for anybody outside of NHS Wales in the coming weeks and months. And so on that note, I will say thank you very much to the panel and to the Value in Health team for looking after us and getting us through this session today. And congratulations to you on what's been a fantastic week so far, and wish everybody enjoyable sessions for the remainder of the day. Thank you very much.
Thank you.